Good morning, Jennifer Carby from the Office of Legislative Counsel. This is the first meeting of the Health Reform Oversight Committee this biennium. So we are going to start out by electing the chair and vice chair. Are there any nominations for chair?
I would like to nominate Senator Virginia Lyons as chair.
A nomination for Senator Lyons. Seconded. Are there any other nominations? Okay. So the Senator Lyons has been nominated. So all those in favor, please say aye.
Aye.
All opposed, say nay. Great. You have a chair. Madam Chair, would you like me to do the vice chair or would you like to do the vice chair?
Either way, go right ahead. You're doing a great job.
So this committee has historically had a vice chair as well. Are there any nominations for vice chair?
I'd like to nominate Alyssa Black as vice chair.
Representative Black has been nominated as vice chair. Are there any other nominations? Second? Get that part? Are there any other nominations? All right, so the nomination of Representative Black, all those in favor, please say aye.
Aye.
Those opposed, nay. All right, the ayes have it, and you have a chair and a vice chair. Congratulations to you both. And I will turn it over to the chair.
Okay, good morning, everyone. This is the HROC. We did have an HROC meeting last fall, but this is the first one of this biennium, and a great deal has happened between last year and now, including some significant federal changes. Today, our focus, however, is on what we're doing in this state to ensure financial sustainability of our hospitals, to efficiently move care out of hospitals to community services and to perhaps retool some of our hospital services, and to ensure that we're seeing cost savings, access, and quality improvement for people of Vermont. In the last year, there was an emphasis on working together. That doesn't change. We're still working together. And I know it's been a great, it's been terrific, to see everyone pitching in and trying to make sure that we have cost effective, I almost said costly, that's a bad word. Cost effective, quality access for folks. It's a little bit scary when we think about the federal government, but that's another topic. Perhaps we'll get into that a little bit today. And I know there are folks who are interested in doing that, but we certainly will be keeping an eye on the federal implications, especially with what's going on right now in terms of our government being shut down. So today is our opportunity to look at what is being done to transform healthcare in the state of Vermont. We've had work going on since 2022, had several bills that have been passed. Most recently, we've had steps toward reference-based pricing and global hospital budgets. We know that AHS is working hard to move care out of hospitals. We're looking at independent primary care and primary care overall. There's a lot going on. I just can't describe it all. I know that maybe Representative Black wants to enumerate a little bit, but I think I'll turn it over to Representative Black for a minute. I'll just let you know that the agenda today was structured based on Representative Black and I getting together with Leg Council and Joint Fiscal and taking their suggestions and thinking about what would be best for us to consider going forward. So Representative Black, any comments that you'd like to make?
I think I would just say, especially in regards to the hospital transformation, there has been some changes that have been happening in the last couple months. A contractor really curious and interested in hearing from AHS around their decision making in that process, and it seems as though they pivoted a bit in the work that had started earlier this year, and really interested in getting an update. That.
Yeah, thank you. I mean, that we'll certainly be getting that from a healthcare advocate. We want to focus really on the work that is, going on, but the contractor piece is significant. It has significant implications, especially for a hospital like Brattleboro that has contracted out its ED completely. So, and the other, and what you bring up is important too, in looking at what's going on, for example, with the Copley Birthing Center and that issue. We want to talk about that perhaps when we have AHS come up. So I don't want to prolong the agony. I know there are many of you here in the room who are not testifying, who have direct interest in what's going on. I include the FQHCs and the hospitals and others. We will get to that stage of testimony, whether it's with HROC or in our own committees, but we certainly need to hear from you going forward. So Jen, why don't you come up and talk with us about kind of the overview? Act 68. I know that we've had a lot of acts.
Members. Yes, Jen Carby from Legislative Council again. So yes, I just wanted to help you set the stage a little bit as you get into your testimony from the Agency of Human Services and Green Mountain Care Board on the work that they're doing. As far as what had been directed through legislation, both in Act 167 of 2022, just kind of what started the transformation work. And that act had directed the Green Mountain Care Board in collaboration with the Agency of Human Services to do a community engagement process for the hospitals to hit a number of goals: reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services. And the following year, you had language that directed the Agency of Human Services to start transformation planning with up to 4 hospitals, to be informed by their data analysis and community engagement that the board and AHS in collaboration had done. And there are a number of reports, and so I've just put this same summary document that I think I walked through last year on the website, the committee page again. There's links to a bunch of the different updates and deliverables. But what I also wanted to focus on and put up on the screen for a moment is the language from what is now Act 68. This was S126 during the session. People remember that. And there were just a few sections in particular that I think are really focusing in on the monthly reporting that you've been getting and the testimony you're going to hear today. So Section 11A directed the Agency of Human Services to work with the hospitals and other healthcare providers to encourage them to cooperate in coming up with some rapid responses to urgent financial pressures facing the healthcare system and identify opportunities to increase efficiency, improve quality, reduce prescription drug spending, and increase access to essential services, while reducing hospital spending for hospital fiscal year 2026, which is the year that has just begun, by not less than 2.5%. It directs the agency to facilitate and supervise the participation of the providers to avoid antitrust concerns. And then it requires the agency to report on the proposed reductions that it has approved pursuant to this section, including applicable timing and appropriate accountability measures to this committee and the Joint Fiscal Committee by July 1st, and then to have monthly reporting beginning on October 1st with updates on their progress in implementing and achieving those hospital spending reductions. I think that's part of what you will hear about today, and you have been getting, I know both committees have been getting reports from the agency. Section 11B required the agency to identify specific outcome measures for determining whether, when, and to what extent each of the 5 goals that I just mentioned earlier in connection with Act 167 have been reached. So that's, again, reducing inefficiencies, lowering costs, improving health outcomes, reducing health inequities, and increasing access to essential services. So what are the outcome measures by which they will determine whether and to what extent those have been met? And they're supposed to report to this committee and Joint Fiscal the outcome measures they've developed and a timeline for accomplishing them, how they will determine progress in accomplishing the outcome measures and achieving transformation goals, including how they will determine the amount of savings attributable to each inefficiency reduced and how they will evaluate increases in access, the impact that each transformation decision made by an individual hospital has or will have on the state's healthcare system, including costs and insurance premiums, how the agency is tracking and coordinating each hospital's efforts, transformation efforts to ensure that they complement and they're complementary across the system and will contribute in a positive way toward a transformed system that meets the Act 167 goals, and the amount of funding that the agency has spent on their transformation efforts to date, and the amount of unspent funds that remain available for that work. And that reporting began August 1st and continues through the end of 2026 to this committee and the Joint Fiscal Committee, and then to the standing committees during the session. And then finally, there was $2 million was appropriated to the Agency of Human Services to award grants to hospitals to actively participate in transformation efforts. And so part of that, we'll have a report due by December 1st on how much has been spent or obligated and how much has been dispersed, although you may hear some of that today, as I believe that work has already begun. So those are the pieces that I wanted to put back on your radar as you get ready to hear from AHS and Remand Care Board on their work.
Questions for Jen? Thank you. Thanks, Jen. Okay. Sarah, welcome.
Thank you. I'm gonna do a little chair shuffling.
Okay. So, yeah, just get yourselves organized.
Oh.
Yeah. Oh, Craig is up on the screen.
Yeah.
So Elena, you're gonna wait for Remand Care Board, or how are we doing that? Because you're also on the list here, and I want to make sure we're not missing anyone, as is Hillary watching.
Yeah.
Okay, that's good. Thank you. Good. All right. So why don't you introduce yourselves for the record? I think we all know who you are, but it would be helpful for the record.
Not all of us.
I don't. Not all of us.
You two do.
All right. Morning, everyone. I'm Sarah Rosenblum. I'm the Interim Director of Healthcare Reform at the Agency of Human Services.
Good morning, I'm John Soroyan, the Executive Director for the Blueprint for Health.
Hi, everyone. I'm Fran Hodgins. I'm the Administrative Services Director at the Office of Healthcare Reform.
And Craig is joining us online. Craig, do you have volume? Do you mind just introducing yourself?
Yeah, I can. Thank you. Can you all hear me okay?
Yes.
Hi, my name's Craig Jones. I'm a contractor and consultant helping the AHS and Blueprint teams with this hospital and regional transformation work.
Terrific. Thank you. So, and before we begin, Sarah, I understand that you are filling in the position that Brendan Krause was in, and he left in September.
Yes, I've been in the role for 3 weeks.
Right. So and just to clarify, so we have a number of reports from you, and the reports that we have are built on the work that Brendan did, as well as you're working with you and others.
Yep. And as Jen said, they continue now through all of 2026. So we have some continuity there.
All right. Okay. Thank you.
Okay.
Okay.
All right, I'm going to kick it off. You can stay on this slide for 1 sec, Brendan. I saw you going for it. Just for folks' awareness, I just want to say the Office of Healthcare Reform within the Agency of Human Services is in the central office, so it does not sit with any specific department. What that means is that our team collaborates with the departments to do our work and implement our work. So just a note about where we all live. The Office of Healthcare Reform includes several different teams. So we have a care transformation team you're going to hear from today. We have the Blueprint for Health. We have a health data team. among others, but you'll hear folks through our AHS testimony today that all represent those different teams that all live within healthcare reform. Okay, I'm going to just do 2 or 3 slides about the Office of Healthcare Reform and our vision for reform. And then we're going to have John, Fran, and Craig talk a little bit more about Act 167 and the hospital transformation work. And then later this morning, we are also going to speak about rural health transformation and that federal funding opportunity.
And thinking about the agenda, and because we have Elena Berube and Hillary Watson also testifying, so we'll go through your initial slides and then we'll come back to rural health after their testimony. Okay.
Madam Chair, would you like questions at sort of the end of each chunk or filtered?
Well, we do want
Sprinkled
questions. We
throughout.
want an opportunity for questions. I'm thinking that it might be helpful to have you go through and then we can get questions of clarity. And there may be some other. We don't want to deviate too much because we want you to get through it all. So,
That's fine.
so the answer, do you want questions in the middle of you? We don't care.
How do folks?
If there's something that really does not make any sense, please stop
Yeah,
us.
I would stop us.
Okay,
And if it can, wait, we'll maybe ask to let it,
got it. Just
That's
let us
okay.
know if it's coming.
don't want to confuse it.
Okay, good. So fire
Thank you.
away.
Okay. All right, so just a few words about what we mean when we talk about healthcare reform, because it's jargony. What we're really talking about is making sure that Vermonters get the care they need, when and where they need it, at a price they can afford. What that means for the system is that it's financially sustainable, that we have improved patient access, that patients are having better care outcomes, and that the system is being supported by a workforce that is sustained and growing. Okay. And what is driving reform? I think you all have seen this slide or a version of this slide many times. I think most of the bullets on the slide will not be a surprise to you. You know, Vermont's health insurance prices have been rising astronomically over the years and are no longer affordable to Vermonters.
So as you're going through this list, and one of the key indicators, one of the key pieces of Act 126 is to have outcomes measurements. And maybe you could indicate here which of these you have identified as initial outcomes that you're measuring. Can you do that and talk about?
I can't do it off the top of my head. Certainly, we can follow up, but I'd have to confirm with the report as far as the measures we're tracking.
Yeah, and I think the monthly reporting that we're doing around measurement does outline based on the goals of the Act 167. I think there's 5 goals in Act 167 and identified, here are measures that speak to access, here are measures that speak to cost and affordability. So there is a sort of crosswalk there between the Act 167 goals and the measures that have been identified in those reports.
And then another question that you can help out with as you're going along is the Oliver Wyman report also has some outcomes that we're interested in. So any of this list or 167, so this is, we also have Act 68 and then the Oliver Wyman report. And how have you called out those specific outcomes that you can measure first, second, third, going forward? I mean, we're getting to the stage where since 2022, now it's time for some results. So.
Yeah.
Okay.
What I think is a silver lining of where we are today in the state of Vermont related to our healthcare system is that I think it has generated a lot of conversation. And we've had several years of talking about the problem. We've had several years of talking about possible solutions. And I think we're at a moment where there is broad agreement that changes need to be made and that we have to reassess. And so to exactly your point, we're kind of at the stage where things need to start changing. And so I think there is some energy around that, which is good. And this is my last slide before I'll turn it over to the team to get a little bit more into Act 167 and hospital transformation. But I did want to just kick off the day and explicitly say that the two topics you've invited AHS to speak to today, Act 167 and hospital transformation, and the Federal Rural Healthcare Transformation Program, RHTP, are inherently related. So our work today on Act 167 care transformation has been informed by years of strategic planning by AHS, as well as GMCB's Oliver Wyman report. That has informed our current work. And in turn, the Rural Healthcare Transformation Program is now an opportunity for the state of Vermont to fund the work that we have already been doing and that we plan to do through care transformation. So Vermont is well positioned for the RHTP application, I think, because we are not looking at ourselves, in this very tight time frame as we develop the application saying, what do we mean by healthcare transformation and what do we want? But rather, we've been doing this work for several years. We're doing the work today, and the RHTP opportunity is a way to sustain that work for future years.
Right, I think I'm going to kick off this next section around Act 167 hospital transportation. Again, my name is Fran Hodgins, and I will be joined by my colleagues, Dr. John Saroyan and Dr. Craig Jones, who is on. We can go to the next slide. So the plan for the presentation today, I'll just start with a little bit of background about kind of what, some of the things we've already covered about legislation, so we can move through that pretty quickly. What some of our priorities are in this work, and then I think we'll spend the bulk of the time talking about the ways that AHS is supporting hospital and regional transformation efforts through technical assistance, regional convenings, the grants that were mentioned earlier from Act 68, and analytics support, which I think also will speak to some of the measurement pieces that you mentioned earlier. And then we'll wrap up with sort of how these things are related, similar to what Sarah was noting. There's a lot of linkages across the work that we're doing, and a timeline review. All right, I won't spend too much
Can I
time.
ask one question for all of you? Maybe you can't answer it.
Okay.
But linking current activities to long-term vision, how long-term are we looking to make change?
Yeah, I mean, as we'll talk about it at the end, but I invite others from the team to talk about it too. But part of what I was linking there too is in Act 68, the strategic healthcare delivery plan is one of the things that the agency has been tasked with in collaboration with GMCB and others. And that plan is sort of due in 2028. And so part of what I was going to draw the connection here is how the work that we have been doing, the work that's currently underway, and this kind of upcoming vision process that we'll be working on over the next couple of years are feeding in together, as well as the ways that RHTP could support that work over the next couple of years. But invite others to chime in.
I think that's right.
Thank you.
Okay. I won't belabor these since we've talked about them a little bit, but just noting that, there have been several pieces of key legislation that have been laying a foundation for this work over the last several years. The Oliver Wyman report, which was published last fall, came out with a lot of important analyses and recommendations for consideration. Act 51 tasked the agency with, moving to the next phase, thinking about feasibility and implementation, what that really looks like on the ground with hospitals. And then we just had a nice overview of Act 68, which also talks about facilitating collaboration and coordination across the system, as well as that strategic healthcare delivery plan that was just mentioned. So I think we can move forward on that. So as we've sort of taken on this work, we've identified a couple of priorities for how we are guiding the big picture of what we're doing. The first one is thinking about how we transform the healthcare system to achieve the goals that Sarah mentioned right at the top around cost sustainability, financial sustainability, workforce retention and growth, patient access, and better care outcomes. We'll also talk today about strategic regionalization of services and what that means, how we're aligning the services that are available in Vermont with population needs, establishing kind of connections and collaboration across the system, and building regional care systems. I'm going to talk a little bit more about that on the next slide as well. And then thinking about how we maintain access to the services that Vermonters need. in their local, at their regional and state level. I did just want to call out here that, today's presentation is focused on hospital transformation and the work that we've been doing, but that first bullet notes that this is a health system transformation, and we know that hospitals are not the only part of our health system. They are, a critical anchor for care in a lot of communities, but the work will and needs to expand beyond the hospital system. When Dr. Saroyan and Dr. Jones chat more about some of the work that has been unfolding over the last couple of months in particular, I think you'll start to hear some places where we're already seeing that work come together. Chair Lyons, I think you mentioned earlier the need for shifting care out of hospitals in some cases to more appropriate or lower cost settings. So we certainly are thinking about that in a kind of big picture way, but the presentation today and a lot of what I will be talking about does have a focus on hospitals.
When you analyze your data for strategic regionalization or patient access, how much are you analyzing the socioeconomic status of folks as they're moving? I know in my region, I live on southeast corner of the state. Essentially, like people with resources are already seeking hospital care outside of sort of basic area, and everyone, and poorer folks are getting local care.
Will, do you mind introducing yourself too, just for the record, since this will tie in the work bit, and we're gonna jump.
If you're gonna talk about this later, I can wait for an answer.
No.
Maybe we should wait.
Yeah, wait.
We should wait. There's a
Remember your questions.
evolving answer that'll be quite, I think, encouraging to what you're talking about. Thank you. Go ahead, Fran, sorry.
Okay, yeah, no worries. We can go to the next slide. So I did just want to spend a moment talking about what is regionalization. I think that's a term that we are highlighting frequently in this presentation, and kind of what do we mean by that. At the 10,000 foot level, we're thinking about how our resources and our healthcare system are optimally distributed so that folks can get access to the care they need when and where they need it at a price that they can afford. And that looks like a couple of different things, or a couple of different ways that we can approach thinking about strengthening our regional system. That could be, sharing administrative services, for example. How could organizations work together to do shared purchasing, or maybe share back office, or administrative services? It can think about how we move patients and transfer patients across sites to make sure that people are getting access to appropriate levels of care. And then it's also thinking about how we redesign our clinical service delivery system. So what services are available at the local, regional, and state level. And you'll see that theme come up several times in the presentation today, and we'll have an opportunity to talk about what that might look like.
And if you're you said come up later today, so if this is gonna come up later today, I can wait. But you just touched on what services where. So whether at the local, regional, and state level, have you reached any conclusions or come to conclusions about at what level certain things should be? So maternal and child health, for instance, pops to mind, since that's been one that's been.
Sure. We will touch on that and that topic specifically later in the presentation. But what I would just say at a high level is that is the work that's underway right now, is thinking about, we've heard from various stakeholders who not always 100% aligned, but, places where there are priorities that are emerging, and places where there's more agreement or more challenge about thinking about what those regional services will look like. And we will talk about that in a couple of minutes.
So let me clarify. So you will be talking about the work that's ongoing, so that gaps in care have been identified, or gaps in community services have been identified regionally. Had that happened? And that was, I think, in Act 167. So that's why I'm asking.
Yeah, I think that is part of it, is where are there gaps? And I think the other part is where are there maybe places where we are offering services in multiple places, that there could be an opportunity for regionalizing that care, because for either volume reasons or cost reasons, it's not feasible for that same service to be offered everywhere. So I think it's both of those things. Where are there gaps? And I want to let others weigh in on this, but some of those gaps are outside of the hospital system too. So if we think, okay.
That's what I'm talking about. I'm talking about the community service gaps, the transportation gap, those things that provide care outside of the hospital and get people.
Yes, and I think this is, when I was chatting earlier, mentioned earlier, we're balancing, like doing this phased approach, thinking about hospitals, starting with our work there, but it very quickly and very immediately, engages the whole system and moving care out of hospitals in some cases.
Quick short question is, and I know that you do have some data on expenditures, how much money, we've given you millions of dollars as for this work because it is important. But then also how that money's been spent and what are the outcomes we're seeing from those expenditures. I know there's some obligated and haven't been used, and I know that the consultant you had is still finishing up. So there's a lot there that we want to get to, and I hope we're getting to that.
Sure, we can, I think some of that will come up in the presentation, but we can certainly, take questions about that too, if there's additional questions. Okay, I think we can move to the next slide. So for the next portion of our presentation, we're going to talk through the kind of package of supports that the agency is working on around care transformation. And I will kick off by talking about technical assistance, which relates to the contractor that you have been mentioning, the Rural Health Redesign Center. So I think many of you may be aware that earlier this year, we started contracting with an organization called the Rural Health Redesign Center. They are an organization that provides technical assistance nationally to hospitals, particularly rural hospitals, and notably administered the Pennsylvania Rural Health Model. They engaged with Vermont's hospitals, 14 of Vermont's hospitals in an analysis and planning discussions starting in the sort of spring and summer of this year. And what we've highlighted here are some of the key outcomes from those, the work that they conducted. So in June, after doing some analysis of hospital data and stakeholder outreach, they held two stakeholder meetings, one in the northern part of the state, or for the northern part of the state in Burlington, and one for the southern part of the state in Woodstock. And we had approximately 165 attendees for those meetings. Kind of an opportunity to bring folks from across the system together to talk about where there were priorities, align on the need for change. It was kind of the first big convening after the Oliver Wyman report had been released previously that fall. And one of the important things that came out of that meeting was this framework around tiering of services and sort of introducing that as a concept and trying to get alignment around what those definitions are and how that might be advancing our work.
The framework for tiering of services, did everyone sort of come to agreement on that framework of tiering of services?
So the way that those
Can we see the framework for the, will we get that? I'm so sorry.
Yeah, if you don't mind, I might come back to this in just a second.
No, please.
And
I'm
then,
gonna stop asking questions. Until
no, that's a great question because I want to talk about
But
it.
to clarify your question a little bit, so are you asking how the decisions are made or?
Yeah, so if this happened with engagement and input, how input can mean a wide variety of things, and what was the level of agreement as part of the input?
So when I hear you ask the question, is it a hospital decision that's being made?
Yeah, that is my.
Or is it a hospital and other data analytics that is saying the hospital may not like it, but this is the important thing to do? So how are those decisions? Is that?
Why don't we just jump to the next slide and we can talk about it.
There you go.
In a little more detail, and then we can jump back if we need to. So speaking specifically about the meetings that we held in June, the way that was structured, the Rural Health Redesign Center sent out a survey to all meeting participants, and it was not just hospitals, it was a broader kind of stakeholder audience, although there was a lot of hospital attendance and participation in the meeting as well. And sort of socialized this concept around tiering of services. And as outlined on this slide, tier 1 is like the local services that are needed in every community. Tier 2 are services that folks need to have access to, but it may not be feasible to have access at the local level. So we need it regionally in every state. And tier 3 are services that need to be available to Vermonters in the state or outside of in a neighboring state, but may not be at the local or regional level. So a pre-meeting survey went out to folks and asked for their input about this tiering concept generally. You know, does this make sense to you that there would be services that fall in these buckets? And then there was a long list of services to say like, what is a tier 1 service? What is a tier 2? And what is tier 3? So that was one input from the meeting, was this pre-meeting survey. During the meetings, we also convened regional groupings for facilitated discussion. And the sort of rough groupings were Northeast, Northwest, Central, Southeast, and Southwest. And again, this was both hospital and kind of broader system participants or health system participants to have these conversations. I think to your point about consensus, what I've highlighted here as examples, these were examples of places where we heard in those meetings and in the pre-meeting survey some sort of alignment, at least that this is a priority area to explore. Not necessarily that every voice, was speaking in the same way. Yeah, go ahead.
So obviously we're reading in the news and we're seeing what's happening to hospitals across the state, and some in particular, I think of Brattleboro right now, where they've had this big administrative transition and they're in deep trouble. And I'm going back to Representative Kornheiser's question because it raises a question for me that whoever's leading this is leading change or leading toward business as usual. And, we do want to save hospitals, and hospitals are good at sort of circling the wagons and taking care of themselves. But at the same time, we've got transformation in our heads and in the works. So how are you fostering change? I know it's hard. We've got reins with the hospitals out there and pulling one way or the other. There's a lot of tension here. So,
yeah.
So this is going to be an ongoing question. How are you dealing with that? And right behind you is the leader of the hospital. So, how is that? How are we going to move away from business as usual? Which is really what this is all about.
I'm happy to
A little bit.
Do you want to jump forward and bring in some speaker? Go ahead, sorry.
In the continuation of Senator Lyons' question, I'm wondering, because, I've seen this and it's been presented. I'm wondering what decisions AHS, Office of Healthcare Reform, are making right now that are deeply unpopular and do not have stakeholder engagement. That's just a question to add to, because I know we've been working very closely with the hospitals. And, sometimes transformation efforts are going to be unpopular. So what decisions are you making that don't have that agreement?
Do you want to jump ahead or do you want to finish?
Oh, it sounds like we should jump ahead.
Okay. Yeah, let me just peek ahead at what else.
It's ahead of us, so keep these
Okay.
thoughts in mind.
Yeah.
So just go ahead.
I think the next portion of our presentation, we are going to talk a lot about what we have been doing and some of the outputs and where we are in that process of supporting the decision making. This is just sort of laying a foundation for where we've been and some of the work in particular that our HRC had advanced. So I just have one more slide on this and then I'll transition it over and I think we'll be able to address some of the questions that you we're just getting at. So we noted earlier that there has been kind of refinement and reflection on our approach and how we're moving this work forward. And we have been thinking about how we continue to align with state goals and input that we've heard from stakeholders and hospitals as well. As part of that, we concluded our engagement with the Rural Health Redesign Center. That contract is actually ending today. And the healthcare reform team and Blueprint for Health teams will be taking the primary lead in terms of convening hospitals and advancing the care transformation work. What you're about to hear about from Dr. Jones and Dr. Soroyan is, the work that we've been doing to convene hospitals and keep partners to advance some of those conversations and strategies. The grants in Act 68 around transformation planning at the hospital level. An analytics vendor that we're planning to procure to be able to support some of the deeper data work that is needed, and the development of state and regional transformation plans. So I'm happy to take questions if you'd like to now about RHRC, or we can.
I'm just curious how much money was spent with RHRC and
Yeah, sure. I think the spend to date has been a little bit over $600,000, but the total anticipated spend by the time that the contract is wrapped will be a little over $900,000. It's roughly a third of the initial contract amount. Great. Well, thank you all. I'm going to turn it over to Dr. Soroyan to talk about some of the work that the Healthcare Forum and Blueprint for Health teams have been leading.
Sure, and thank you. It's wonderful, excellent, setting the stage. And I'm gonna speak to slides that are coming up and then refer to Dr. Jones. Craig, if that's okay, I'll just take the lead and then ask you to comment on some specific areas. So the Oliver Wyman report and RHRC's initial report was critical for not only setting the stage, but getting into specifics of topics that are unpopular and that are difficult to talk about. The meetings in June, both in Woodstock and Burlington, were very well attended, and there was a tremendous amount of discussion in very large groups and circles with many different participants around the table, simply not just hospitals, though they were there, but as Fran said, hospice, home health, members of the primary care, and even subspecialty groups that were there, not to mention members of the community. Our regional health system groupings began very much with what RHRC had led as a template. And to get back to your question, Representative, I found it very useful, and I think others did. And this is also named in the legislation, to learn from other states and take examples from other states, just like Dr. Hamry did from his experience in the Geisinger Health System in Pennsylvania, as well as RHRC did with CEOs, CFOs, leaders looking at what worked in Pennsylvania and what they did to solve similar problems here. So I think that outside state expertise, which is what we're called upon to draw on, is very much useful in both of those reports as we then take the specific topics and issues and customize them and really get them down here. So if we go to the next slide, sorry, I got talking too much and didn't go to the next slide. Thank you, Brendan. These were the groupings of hospitals. And I want to note this is startings of conversations. These were with hospital leaders to articulate their opportunities. I just want to emphasize, as executive director for Blueprint for Health, I very much implemented parts of Act 167 in terms of expansion of community health team. I was called upon in Act 68 to convene the comprehensive primary health care group. So I'm very much aware of all of the areas outside of the hospital: primary care, specialty care, MOUD, hospice and home health. And stepping into this role for me and for Craig and the team was very valuable to speak to those hospital leaders and really call them to the table in a way that RHRC had laid the groundwork from their time that they had invested into getting specific topics in their work with specific hospitals. I will say before I move to the next slide that the central region of this slide was changed from RHRC's recommendations, since the feedback we were getting was that the spine of the Green Mountains, according to our partners in the Northeast Kingdom and Northeast Kingdom, made collaboration and initial discussions, and that this is going to change. This is not static. We're changing on topics, but the initial grouping was in this format that you see. So I'm happy to take any questions about this. A lot of time went into RHRC's work and our work into making sure that first group of meetings was this grouping, but already in the meetings I'm starting to convene starting next Wednesday, some of this has already changed. But I just wanted to give that context. And
I have a quick question about this. I understand that we don't have any regulatory ability over Dartmouth whatsoever, but are they engaged in any stakeholder conversations with you? And are they in the Southeast region? Are they everywhere? Like, how do they fit into the conversations you're having, if not?
Yes. Dartmouth Health, the topic that came most to kind of thematically across different regions, and there's different
But did representatives from Dartmouth attend any of these?
they're attending my meeting Wednesday.
Okay, great.
Yeah, and they're attending the meeting in the Northeast Kingdom following that, and they're attending meetings at Grace Cottage, and they're attending meetings at Brattleboro Memorial Hospital.
Great.
And two of our hospitals are Dartmouth Hospital owned and affiliated. And so by meeting with Tom D in Southwestern Medical Center and his hospital, we were getting a lot of input from Dartmouth Health, as well as meeting with Dr. Foster at Mount Escutney and his team. So they were very much engaged. And I quickly, as I heard the different themes coming, also engaged other parts of Dartmouth Health's leadership that is topic specific, and that will continue. It's also been asked upon us to not just include that end of the border, but also academic medical and medical centers in Massachusetts and New York. And I'm laying the groundwork to try to get them to the table too when specific topics have been called upon. That's been a very valuable
That's very reassuring. Thanks.
Similarly, with UVM network. UVM is up there.
UVM Health Network in the topic that I'm convening on Wednesday will be at all of those meetings too. Yes, both of them. And really a high amount of awareness to making sure that there's not too much emphasis on hospitals, and making sure that we're responsive and they're at the table, but we're absolutely bringing in community partners and subspecialists, primary care, home health, and eventually just the whole spectrum of care. And I'm going to lay out for you what we are doing right now. And I'm happy to talk about what's next, in addition to what slides I have here, but we should probably go to the next one. Senator Lyons, go ahead. Jeff.
Good, thank you.
When you were just outlining, can I just say?
Oh, of course, I'm sorry.
Long-term care.
Too fast.
No.
So our Dale commissioner, Commissioner Bowen, and Fran has been instrumental in her work, is ongoing with hospice, with home health, with aspects of long-term care as well. And that is a work that Commissioner Bowen, with Fran's assistant and others, has been leading. I attended their last meeting, and very much my plan, and Commissioner Bowen and I have had some initial discussions about this, is that there's going to be timing for those things then to overlap, the work that she's initiated specifically to Dale's oversight. Did I get that right? So yes, that actually has been going on for
Yeah,
longer though.
yeah, we started, I mean,
I don't want to sidetrack you. I guess I was just wanting to
Please.
make sure that long-term care is part of that
Yes,
discussion.
yes.
When we're looking at overall health
Yes.
systems, because there's lots of issues with integration with healthcare. And not only you were talking about home health, so I was also thinking about rehab, nursing facility, res care, home and community-based services, all of those things
Yes.
tie into that. Okay.
I'm a certified hospice medical director. I did hospice from 2013 to 2022. I've been in, 85% of our long-term care settings and like physically in them. So yes, it's extremely important to me personally, and also in terms of this work that's been called upon. And Senator Lyons has been, I think, from our earliest conversations in 2022, and the language in S285 and then Act 167 has been very much grounded in that type of work. So yes.
Great. Thank you.
So on the top left, there's a lot of information on this slide, and I'm going to let Dr. Jones jump in just a minute, but I am going to go through these tiles if I can with you. Interfacility transfer coordination, and I'm going to be, I'm going to try to speak sort of John speak as much as possible. At the same time, though, we have a lot of terminology that's necessary to just name, since that's what the terminology is. So when I say interfacility transfer coordination, that may mean going between two hospitals, from a smaller hospital to a larger one. That may mean traveling out of state. That may mean going from a hospital to a respite house, for example, like the one in Colchester or in Lebanon. It also may mean going home. It may mean going to a skilled nursing facility, but it may mean going between a mental health setting and another mental health setting, or one that's related to substance use. So when I say interfacility transfer coordination, this is work that has begun is going on and probably will go on for quite some time. We're partnering with the Department of Health quite closely on interfacility transfer coordination. The meetings that we're convening that will include Dartmouth Health and UVM Health Network that I was naming just before is focused on EMS presence, clinician and nursing presence, and leadership around interfacility transfer coordination in different regions of the state, not necessarily what I showed you on the map. There's been some stars that have been moving around based on transportation. We are in the process of defining what the goals and what the measures will be for that. But in those initial meetings, interfacility transfer coordination came up so frequently. In some places, just great. I don't want to be overly negative, and you know me well. There's some places that really have it right that we need to call to the table to help other parts of the state. But this is probably the most immediate thing, like coming up Wednesday and in the month of October that's going on. And I can speak to the specific terminology up there around capacity management, specialty coverage, hospital to hospital transfers, but that's the upper left tile. So that's one thing. And I just want to make sure all of you don't think that's just hospital to hospital.
And
Go ahead, Craig.
yeah, no, thanks, John. I just wanted to jump in on that. It goes back to some earlier questions that were being asked about the array of impact and measurement that will come to play here. So when we talk about capacity management, a lot of the terminology that's used is acuity management. And so, for example, you talk to a small hospital, 25 bed, and they have trouble because they can't transfer people out that need a different level of service. So this is about, in part, helping them with the efficient transfer of people that need higher levels of service, and in doing that, opening up beds in their hospital so for people who need services they can provide lower acuity. And so there's an efficiency in this. There's patients getting the right care at the right place in this. And then there's also, by managing acuity, a cost efficiency at the hospital. So there's going to be a series of measurement outcomes that are impacted by this category. I just want to highlight that for you. And then also, when we think about the groupings on the previous slide, and you were asking questions about the involvement of the tertiary centers and others, this is one of those that's going to be cross-cutting. Those regions, as Dr. Saroyan said, are fluid. So, for example, you may talk within a region where they need to manage their acuity together on certain services, but there's others that are going to require the tertiary academic medical centers, both Dartmouth, UVM, potentially others. And so we'll see the lines be fluid in who's involved in these conversations, as Dr. Saroyan said. And I just want to highlight that for you. So the planning, the identification of the opportunities, the efficiencies, measurement, all tie together. This is a good example of how, even though we start with certain regions, that quickly extends to how can we have a coordinated, centralized transfer and transport process that optimizes acuity management efficiencies. And then there's the resultant cost impacts and quality impacts as well.
Thanks, Craig. And Representative Black, if may I just weave in a question you asked before into this specific tile. Unpopular topic, and this came up very early, and they said no to this transfer. They said no to this person who needed care, and ended up going to Hartford, Connecticut. And I'm not going to, this is across the board. I heard this story over. So that is a deeply I wouldn't say it's a deeply unpopular, it's a deeply important topic. That's a difficult topic that by these convenings, I really want to hear, watch, see, and then direct as AHS, quickly jump in to the authority we can, direct to make that better and stop, some of those scenarios from happening as much in the future to the extent we can. But that is one topic that just, and there's others coming up that I'll name, but it's specific to interfacility transfer. That's probably the one that hurts the most. And when I talk to these leaders is, why did that person from our community have to go so far out of state, last month or whatever? And everybody else may have gotten a yes for the other 10 patients they asked to transfer, but they remember that the 1 out of 15 or the 1 out of 20 that was so important because they maybe ended up leaving the state completely to get acute care.
May I ask, what is the cost of care at Hartford
Right,
Medical?
exactly, and that's what we're,
Opposed to-
that's what I want to be able to dig into, and it's much higher. Qualitative.
Higher?
That's what I've heard. That's what I've been told. It makes sense with my experience. I can't give you the numbers. I mean, but that's the work that we're starting to do, is to say, to first point it out as the problem, and then to really look with these additional analytics to ask ourselves those questions and get answers.
Or
Yes.
the cost and the quality,
I would agree with you. Yeah, and again, and I'm speaking as a physician, I can't make generalizations. The people were doing the best they could in that moment to get the person's care, and that person that may have gone wherever, perhaps it's perception that needs to be looked at. But I think, and what I'm hearing from our partners, not our partners, but our academic medical centers, is they are already in the process of doing clinical reviews and quality reviews themselves that sometimes involve finances. And I want them to be able to speak to that level of their own oversight and reflection and inclusion with hospital leaders and EMS present. So they already are doing those things, but I think it needs to be better known. Senator Lyons?
Yeah, so I mean, we've struck a whole lot of chords going forward for, the analytic framework. I see that on your next page. I'm going to ask a question about that. I'm also hearing quality, which we have been asking about now for a long time. And what are our quality metric? Where do we have a centralized location for that information that is broadly shared, that we build on policies, not simply collection of data? So it's all of those questions. I know Hillary's sitting back there, we're waiting to answer that question. But so going to the next slide.
Oh, sure.
I'm going to jump ahead. Don't jump ahead.
Oh.
You may not be finished here, but I'm just going to bring up the Copley
Okay.
Birthing Center and what analytics were used for that decision making. So that decision's made. Now we're going back and we're saying, oh, we should have had analytics. That's what I'm hearing. I'm hearing that data wasn't used for that. I'm hearing that that was maybe hospital driven. I don't know. I mean, it feels that way. And so it's a decision for financial sustainability in one little place without regard for the region or the state. That is what is concerning all of us, I think, sitting here. So some proactivity is important. Now we're hearing Monday morning, we're hearing, oh, now we need an analytic framework in case we have a birthing center that comes up. We need analytic frameworks for everything, and we need quality metric analysis that's going to take patient access and quality and cost reduction forward. So there's a lot of passion around this table on all of those things, and I think it's shared. But I think the shared part for me is allowing for you to take some leadership on this going forward. Not that you're not doing that, but I think we're feeling a little bit of frustration because what we're hearing are things that we've heard before. And now we're hearing, gee whiz, we need an analytic framework. We needed that analytic framework yesterday. So I'll stop there. I'll let you go ahead here but you're hearing some of the concerns that we have, and I appreciate the work that you're doing. It's not that. Okay, need the next step.
And I think, I'll just say, I think Senator Lyons help talk about what is developing to answer the concerns that you're raising in the next couple slides. And John, go ahead and finish. But some of the questions that you're raising, in fact, are critical to the work that is being done. And we'll address that in the next couple slides.
Cool.
Sure. Why don't we move forward? Because I
Go right
feel
ahead.
like I'm taking up too much time too. Can anyone help? I don't know what time it is or what you expect, but I'll just keep.
Well, you have another hour. And we've got,
Care board though.
but we've got the Green Mountain Care Board coming up and we don't want to lose them.
Right.
So, you have another 20 minutes. The most.
Thank you, Senator Lyons. Thank you. Outputs from regional hospital meetings. I didn't in the previous slide talk about the New England Collaborative Health Network. Is that something that's familiar to members of the committee? Okay, so we've certainly engaged in them, and I've very much learned about their utility. Again, not just with hospitals, but with federally qualified health centers, with home health and hospice, and want to learn more and see more and lead where possible that those efficiencies can be greater duplicated across settings. I think I touched enough about hospital to hospital transfers. On the hospital side, I do want to add are working with the Department of Health and their legislative report, Senator Lyons, that's due I think in December, and our work with them with this work so that it's really overlapping and there's leadership, not just from one area, but two areas and more, as well as at the local level with emergency medical services. And that template around interfacility transport will be repeated across the state. I already told you all about that meetings. I'm going to let Dr. Jones probably talk more about the analytic framework and the coordinating with Green Mountain Care Board part. So Craig, do you want to jump in more on that, or should we keep going to some more slides that are specific to labor and delivery?
I'm happy to, if you want, because those questions were
Yes,
raised.
that's what I was thinking.
Important issue. So I can't not speak to Copley or how decisions were made at Copley. However, birthing centers and delivery is a common question mark across the state in how to optimize efficiencies for that. And when we talk about an analytic framework, that means that we're putting together the ability to produce analytics that will answer a number of the questions and provide data, the measures, but most importantly, the insights on what the impacts would be if a particular birthing center or set of birthing centers were in fact closed or changed. And it's not simply about the service line changing, it's about are there ways also to improve support for higher risk pregnancies so that in fact we can modify the profile of how deliveries occur around the state. So HS is working on analytics that not only look at drive times, that's a critical thing. What happens when, we'll show you an example of that. What happens when you change access to birthing centers at a hospital in terms of drive times, and drive times for cesarean deliveries, drive times for vaginal deliveries. But maybe more importantly, how that relates to quality, how that relates to managing higher risk pregnancies, and that translates back, what's the need for support? Maybe better prenatal telehealth support in outlying areas can modify the risk profile and enhance people's access to the services they need. There's a complex analytics approach that's being put in place to help inform those decisions going forward. And it's not just reactive, Senator Lyons. I think to your question, if I heard it right, what's being done is work on a prospective look that if, for example, we wanted to preserve certain drive time benchmarks for cesarean vaginal deliveries, we wanted to preserve quality ratings for delivery centers, and that may include things like the numbers of delivery a center's done, but there's also a number of metrics nationally that are used to assess quality at birthing centers. If we wanted to preserve quality, preserve access through drive times, preserve access through better prenatal care, the analytics will inform which scenarios could best fit. How do we optimize these? So we're doing prospective modeling as well as the modeling that is going to respond to hospitals that may say for financial reasons or business reasons they want to consider changing a birthing center. Birthing center is just one example, but let's use it. So we have to be able to respond to those inputs from hospitals, and we also have to do prospective modeling that anticipates what changes in delivery profiles result in the best outcomes. That analytics is being worked on right now. It's part of a larger advanced analytics approach, and it will be used to inform the decision making, but also the regional planning that Dr. Soroyan's been talking about. I want to just also highlight that the initial rounds of meetings with hospitals and others, as it extends to other stakeholders, has been really energetic. It has not been, to the earlier question about defensiveness or just circling the wagons necessarily. It's been energetic input collectively. And that's one of the reasons we had to go to AHS team leading these conversations. They needed the cover for antitrust issues. It's the reason that RHRC had difficulty with this type of work, because the hospitals wanted to engage with AHS in that forum. But now that they're doing it, it's energetic. They're proposing difficult changes, and they're looking at, as this slide highlights, shared business, administrative, and clinical opportunities. Shared. Let me stop. Yeah, I'll stop there. Go ahead.
Yeah, so let me follow up. So very briefly, I'm hearing a lot of work that's ongoing. Key to this is saving money for Vermonters. How have we saved money for Vermonters? Has closing the birthing center saved money for Vermonters?
And that's part of the analysis that we'll.
Okay, well, that's part of the analysis. And we also had a closure of a primary care clinic in Wakefield. It was categorical. It wasn't by us. It wasn't by you. It was by the University of Vermont Medical Center.
Health Network.
Health Networks, thank you. But it was a closure. And now, again, how are we going to prevent those things from happening without knowing that patients have affordable access to care? So I hear what you're doing. I think it's great. We've had work going on now for several years, and we want to know that we're seeing the reduction in cost. I know that Act 68 said 2.5% reduction in healthcare spending. That comes, it can't come at the cost of access. I guess that's what we're saying. Okay, so.
Let's talk about some of the Act 68 hospital transformation grants that we're working on this week. I'm sorry, Representative Black, go ahead, please. Sorry.
I actually have a bit of a technical question. I'm sorry, excuse my ignorance. I haven't been around very long. I know, Dr. Jones, that you have been in the healthcare sphere for many years, but frankly, I'm not quite sure what your role is here. And if you could just, like, where is your area of expertise and why were you brought in? And what exactly are you doing in regards as consulting on this?
Yeah, sure. I was asked to help work with the AHS healthcare reform team and the blueprint team on in strategic role and facilitation role with this hospital and regional transformation work. I guess in part that was probably based on my past experiences, which are long-term, and have run healthcare transformation programs, including primary care transformation programs with the Blueprint for Health in the state of Vermont, and also worked on transformation models as a support contractor with the Centers of Medicare and Medicaid Innovation. I was part of a consultant team that was worked with CMMI on their primary care transformation models and their learning system activities. And that included a number of things, including the use of data to help states around the country with their transformation models. So I've got a number of years of experience with this, and am familiar with the Vermont landscape and was asked to help support the team. So that's my role in this as a contractor. I'm sort of a cross-cutting support to this team in several categories.
Thank you.
Let's go to slide 22, Brendan, and talk about some of the Act 68 hospital transformation grants. And Fran, if you could help me with
Sure.
that topic. Yep.
Sure, I can kick off and then definitely invite.
This is going on right now.
Yeah.
So, yeah, very important stuff.
So as you are all aware, Act 68 allocated $2 million to AHS to provide grants to hospitals to support transformation efforts, collaboration, and cost savings measures. In September, We launched a grant program, which we titled the Hospital Transformation Grant Opportunity, to support hospitals in the development and implementation of hospital and regional transformation plans. Through this opportunity, hospitals can apply for approximately $150,000 in funding to support both the kind of planning and analysis that might be needed for the I guess how they put in place some of the transformation strategies and work that John was talking about before. Different hospitals have identified different types of needs that they may have. Many have identified, we need support around analytics. We don't have like the analysts that can be dedicated to this, or we don't have that expertise in-house, or we want to, contract with somebody else. Or they've identified regional strategies, transformation strategies that they want to move forward, but they need some sort of seed or startup funding to get the ball rolling on that. So we launched that opportunity in September. The applications are due to AHS tomorrow. So we have just started to have a couple of those applications come in this week, and our team will be reviewing them next week. And I think a notable piece of this is that hospitals are required to submit materials back to AHS as a condition of their participation. And we see this very much in sync with the regional convenings that we're doing and the facilitated conversations that we're having. So
I have a somewhat technical question about that. So one, the grants, it sounds like, are for like essentially like localized strategic planning, and the actual cost of the transformation would be a separate thing. And so then my follow-up question to that is, do the plans that are due back to you require cost analysis for those transformations? And then my third question is, do you have an expectation that every single hospital system is going to participate in this? And if they don't, what are you going to do about it?
okay, I might try and
I will.
all those.
I'm so sorry to do the three-parter. It was obnoxious. I didn't mean to.
So you can keep.
I'll try to help, yeah.
To that. Okay, maybe we'll start
The
with
third,
the third one.
and then go to the second. Yeah.
So we, have invited hospitals to participate and apply in this. We can't compel them to participate in this, although I will note that all the hospitals have been actively participating in our regional conversations and in the transformation work to date. So I hope that energy is continued in the participation here. And I know our team has done outreach around that this grant opportunity to all of the hospitals as well. So we'll have a better sense of that participation level, I think, once the application period has closed.
If it's the last day of the application period and you notice that there's 4 hospitals that haven't applied, what's your plan?
Fortunately, a couple have already asked for more time.
Okay.
So there's a lot of communication going back and forth. There's a lot of help. There's a lot of feedback before the applications come in. I've been part of saying, okay, we're going to help you, but it needs to be due by this time. Your second question was analytics, and there's a procurement that's begun, and I made you stand up last time, Will, so I'm not going to make you stand up again. But Will Dempsey, who's here in the room and is our health data officer, has been working hard to make sure that analytics support is available quickly, also from funding. And then your first question was regarding the grant money is not for transformation actions, it's for the planning. And that is correct. It's for the planning part of transformation. And the plans are due very soon. They're due at the beginning of next year.
To get more explicit about my second question,
Okay.
when the plans happen, when the plans are submitted back to you, are they required to include the costs of those transformations?
I guess the question is, what are the guidelines for the RFPs?
Sure, we can
asking for.
get you a copy of it. You know it well. so-
Yeah, I think it's a great question. So what we've sort of had these 3 time points where there's reporting that we're, going to be requesting back. The first is part of the application. We asked for an outline for providers to speak to what are some of the priorities and needs that you have in some of these key areas: hospital transfer, shared business opportunities, and service redesign. The next 2 pieces, transformation plans, the draft and final, we have not put forward yet like exactly what the template for that will look like. Although even in the initial outline, we did say, what would be the kind of costs and needs associated with this. So I think my honest answer back to you is like, that's a consideration for how we structure the next couple of deliverables. And I would also maybe just link the sort of planning versus implementation to also thinking about what is the other funding and other opportunities through either the state, but also through federal opportunities that might help advance the implementation of this work over many years.
So the reporting guidelines are not included in the RFP, and those are not entirely clear to you yet.
We have a structure for what we anticipate the template will be, but we have not shared that template back with hospitals yet.
Not finalize the template.
Representative Shaw.
Thank you. So $150,000 isn't very much, and I'm a little worried that they could spend the entire amount doing their reports back to you and administrative things as opposed to actually getting the work done that needs to be done. So I just hope that whatever it is you're asking isn't too much too often, but still gets to the essence of whether they're on track or not.
Yeah, that was part of my question.
And it's been our intention with the application process and the amount of assistance that we're giving them and feedback, and the length of the application is in that spirit and in that letter. And I anticipate that we will continue to guide it in that manner to the best of our ability, while it still gives substance and deliverables.
And so building partnerships is part of this, I see in the summary report that you sent us. And is there a requirement in the proposals that they work with closing gaps within the community, whether it's long-term care or mental health or whatever?
I've been pushing them all hard to reach beyond the walls of their hospital on a number of topics, including
And moving care outside the hospital, utilizing empty space for other purposes. Yeah, okay.
Yeah, and I would just note on that, we intentionally use this language in the guidance to note that it's a hospital and regional transformation plan. It's not, our hope is that it's not just only focused on the things that are happening within the walls of that hospital. And we also open the opportunity for hospitals to think about if there are places that they want to use these funds to work together. The awards will be made individually to hospitals, but hospitals can, coordinate how they're using these funds if there was a regional strategy or resource that they wanted to be able to tap into to advance something, that was allowed and sort of encouraged in this too.
And if I could just add into that a little bit. So to the first question there, these grants, the 150, you're right. This is not for the costs of implementing the transformation work. This is to help them with the cost of planning. And many of them have expressed the need for consultant help with their planning. And so this is really purposely for planning. The request to them or the call to them in the RFP for the planning does include questions about changes in their own hospital as well as regionalization, and encourages them to work together, as was pointed out, to put those plans together, including estimating the impacts that it'll have on services and access and cost. And then lastly, I would think about this plan support with them, the transformation grant plan, as part of a package. And another part of the package of support is the advanced analytics RFP that is just about to go out. And this is very advanced in terms of addressing scenarios, modeling optimization scenarios, as I mentioned earlier, including cost and quality and access, the changes and impacts that will be made through the plans that are submitted by the hospitals. So there is a package here so that there actually is evidence-informed planning that emerges out of this early next year. And I just want to highlight that as a package for you, because you asked really good questions about measurement and about looking at this objectively. And these grants are modest, but they're support for the work the hospitals need to do. It's combined with the advanced analytics that Will can speak to more in depth in order to get AHS the information it needs for helping the regional work.
So I know we're actually at pumpkin time, but so it's October. So I'm looking at one of the reports that we have on the joint fiscal webpage for our committee. And it has key outcome measures and expenditures, encumbrances and so on, the amount, the money that's been spent. I would like to allow for you to finish up. I'd like to give time to the Green Mountain Care Board. So if you could give us a really short and quick ending. When we get to the rural healthcare report piece, I might ask you to come back to the financial page or the finances of this. And because we've given millions of dollars to AHS in this work, and I'd like to know exactly what, how it's been encumbered, obligated, and how it's being utilized. But why don't you-
Mike, I can
Yeah,
kind of
let's
close
wrap
us
up.
out quickly on this one. This is just sort of intended to be that summary that we touched on right at the beginning of how some of these pieces are relating together. You know, on the left-hand side here, you'll note in gray, many of the things that we've talked about today, the regional conversations, strategic partnerships that we've been advancing, that Dr. Soroyan and Dr. Jones have been facilitating those conversations, the grants, which we just talked about, and sort of woven throughout this need for a new analytics vendor and additional type of support. We're taking all of those findings and as well as other stakeholder input and input from you all, and thinking about where there are these strategic opportunities for the state. The measurement piece of this, how are we going to measure our progress moving forward? And that is building out the development of regional and state plans and ultimately leading to the Act 68 Healthcare Strategic Delivery Plan. And we will, when we come back, or when our team comes back, we'll be talking about the Rural Health Transformation Program. And I think you'll see many of the themes of planning and things that we've been talking about in this presentation coming up again there. And again, thinking about how we pair sort of the analysis, the stakeholder input, the planning work that we've been doing with the how do we get it done and how do we advance it is sort of a piece of how we're putting this all together. I think we can probably wrap up there, but I will note that we have lots of information on our website as well, including a timeline. We post bi-weekly updates about our work on our website as well. And we're always available to meet with you and discuss in more detail. So
Thank you for that. No, thank you all for the work that you're doing. You hear the concerns that we have. We're really interested in seeing some transformation. I see the timeline that you have. It may be that we come back to this as a committee before session or shortly after session or during session. We really need to get back to all of these issues, and we haven't heard sufficient about primary care, obviously.
Okay.
Go ahead.
Just a quick question on time. When is the Act 68 strategic delivery plan due?
2028. So
With annual updates in 2026 and 2027 to you, due to you.
of course, you know, for many reasons, we need to be doing that work between now and 2028, but also thinking about the RHTP program and, you know, those opportunities are coming more quickly too. So.
And a follow-up question to that is, obviously, you no longer have the rural folks, your consultants. You haven't finished paying them, but there's still some money left over, some resources left to engage others to do the work. My concern is that the resources at AHS may be insufficient to do all the work that's demanded of you in this legislation, and that is exactly why we've given some appropriations. So if we, at some point, we would like to come back to this question. That. Great. Sarah, you're on hook for that. Thank you.
Thank you.
Thank you very much. You take your time. All right. Now we need to hear from the other partners in crime. Green Mountain Care Board.
How many chairs do y'all need? 3. You want more?
Can we take a moment to switch and hook up electronics?
Sure. Go right ahead. Everyone that's, how long do you think? Minutes? Oh, 2-minute break. Okay, offline, 2 minutes. We'll come back.
Did you move these two?
Huh?
Did you move this up here and this down here?
No, they're still part of it.
All right, you're live again.
All right, we are back live. This is the healthcare reform HROC. And I was reminded how it got started. The name got put in place today. Okay, so we are back looking at where we are with transformation work, and we have the board with us. So welcome, and familiar faces to most of us, and to a new face on the board. So why don't you go ahead, Elena? I don't know who's in charge here. Just introduce for the record.
Good morning, everyone. My name is Emily Brown. Nice to see you all. I have joined the board as the new executive director effective in August. So I'm happy to be here and continuing to work on these important issues.
I'm Elena Barabee. I'm the Director of Policy at the board. And I'm Hillary Watson. I'm the Health Policy Analyst with the board.
Terrific. Thank you all. Why don't you just share with us what you have? Is this, we have your handout and you have the overhead.
Slides, and I think, we're excited to see the conversation evolve. So we may, if you'd like to move along, some of this is more background, but we thought it was important context to kind of remember where we came from and the work that we've done. So we'll dive in. So we'll cover a short history and the Green Mountain Care Board's specific role in transformation efforts to date. So I think we all know, I won't spend much time here, that rural hospitals have been and continue to struggle nationally. Rural health is increasingly challenging to deliver. And there have been many hospital closures and service line closures taking different shape and form over time. And these have really accelerated since the pandemic. So this is not a trend that has been going away. If anything, it's kind of more pertinent than ever. And then I think, at the time that we really started talking more often about hospital financial health and transformation was really before the pandemic even started. We noticed declining hospital margins. We had a bankruptcy that was no fun for anyone, and really came together. I think you all brought us in to start thinking about what we should be thinking about differently as we try to find a path forward. I won't spend too much time here. We know that at the same time, we have an incredible affordability crisis that is still unmanaged. We're doing as much as we can at the board. Certainly, we know that hospital spending is a major driver of this, of our overall spending. And that our operating costs really, since we started talking about this in 2019, have continued to increase. So I think from 2019 to 2026, hospital operating expenses have grown 53%. And you're controlling prices is going to be essential to that. But if we don't kind of get a handle on the operating costs and how we're delivering services, and making sure that we continue to have access to essential services. And this is why transformation is incredibly important. And, I'm putting this up here, you've probably seen this and you'll see it again. We bring this every year. These are the hospital operating margins. They don't look much better than they did in 2019 earlier. Hospitals continue to struggle with, despite this growth in operating expense, how they're going to make their budgets. So they're making hard choices about how to move forward, which services to prioritize, where to, how to maximize revenue and serve Vermonters. And so I really want to put this here. These are not always mutually exclusive, but I think we need to recognize that we need to think about both affordability and solvency at the same time and what that looks like and what we choose to deliver while we're trying to figure out what that right amount is. So I won't reiterate all of this, but this is just to underscore, really in 2019, we started talking about this. There was the Rural Health Services Task Force. The Green Mountain Care Board required 6 of 14 hospitals to develop sustainability plans in response to the increasing commercial costs and declining margins. In 2020, we extended this to all hospitals and started with Act 159 that asked the Green Mountain Care Board to provide recommendations on improving hospital sustainability. Since then, we provided those recommendations, which turned into Act 167, and then subsequent work. Some of the work that the board did was around the community engagement, which Hillary Watson will speak to in a moment. And then in Act 51, we really kind of handed that work over, and I think that's what we've been talking about since then. So I just want to kind of highlight some of the key points here, and then Hillary will take us forward. And I think I really want to underscore transformation is incredibly important to making sure Vermonters continue to access the services they need. Sounds like we're all kind of in agreement on that. And then payment and delivery system reform must be in line in order to ensure that tangible improvements in cost, quality, and access can be made. So as we move forward, we think about the $12 million that we're allocating to transformation, thinking about what it is that we want, where we want to end up at the end of the day is going to be incredibly important. What are we going to get for that money, and what is it going to look like for Vermonters to access care, and how are they going to pay for it? And then the statewide strategic plan, while expected in 28, is going to, kind of guide our efforts. We're thinking about how we work together with AHS to really think about what this looks like in the meantime, and how we make sure that our collective work is aligned and really we're all going in the same direction. So I think that's going to be really important to making sure we use our limited resources efficiently and that we deliver the best possible outcomes for Vermonters. So we're going to really talk about the community engagement work and underscore the work that we've done. If this feels repetitive, I'm not sure kind of everyone's level of engagement. We're happy to move faster, but here you go. Yeah.
Great, thank you. Yes, so please give us feedback as we go along here. If this is information that you all feel comfortable with and don't have any questions on, we can certainly sort of breeze through it. But as mentioned, this morning, many times, Act 167 charged the Green Mountain Care Board in collaboration with the Agency of Human Services to develop and conduct a data-informed, patient-focused, community-inclusive engagement process. And we also touched on how that was meant to help hospitals reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services while maintaining sufficient capacity for emergency management. So this was certainly a big ask, but one that we really took on in earnest because as you just saw and Alina walked us through, this legislation stemmed from many years of raising red flags about the crises that we are seeing play out today, right? Hospital sustainability and healthcare affordability.
So when you're talking about this report that's come back, is this the final report, the Oliver Wyman report that you're talking about? Just for clarity.
Yes, this is, yes. So when it was released, yes, just over a year ago now.
So, and the Oliver Wyman report in many ways has been influencing the work that we've done in the legislature, but also the role that the board and AHS are playing. Yes.
So we just wanted to start by providing this quick overview of the engagement process. So there's a lot of text on here. I don't expect folks to be able to read all of that, but I just wanted to share, how we really worked throughout this process to maximize engagement and community feedback in each stage. So, as has been mentioned, we began this work in August of 2023 with a series of meetings with stakeholders to help us develop the engagement plan itself. So this was really going to be the roadmap to complete the rest of the work. And it was really critical to the effort that folks were engaged early on. They had a chance to help inform that plan and help us engage with as many folks, providers, community members as possible throughout the process. After that plan was finalized, we set out on what we called a listening tour. We held 2 virtual public meetings in each of the hospital service areas. One was specifically geared towards providers and one for general community members. And
Then over the winter, that kind of qualitative feedback was merged with the analytics that had been performed. And the Oliver Wyman team really began to synthesize their findings and start to sort of construct those options and recommendations. So the data and then those draft recommendations that we all have reviewed and are working from were brought to hospital leadership for discussion and refinement. And then come last summer, we entered sort of the final phase, and that was another robust kind of community engagement effort. We went back out and held in-person community meetings in each of the 14 hospital service areas. And the turnout, we just can show you, was just tremendous. We had such great engagement across the state. So you can go to the next slide, please. Just a quick breakdown of the engagement numbers, right? We connected with over 3,000 people across Vermont, and meeting attendance ranged from about 30 folks to almost 130. We also received 120 written public comments. Next slide here. So this is really where we just wanted to highlight some of the key takeaways from this report and this effort. This slide, again, has a lot of text, but the key takeaway here is really in the title. So the report called for transformation across 3 levels, right? Statewide, the regional level, and then at the individual sort of hospital level. And at the statewide level here, it called for foundational efforts to expand housing options, build and retain a robust workforce, and enhance and better coordinate transportation options. Also mentioned in the statewide sort of bucket is building on community care models and simplifying administrative processes to reduce provider burden.
It sounds so simple.
Right? I know. Then we get into the middle tier there. So at the regional and system level, right, it called for specialized centers of care to drive hospital efficiency and quality, and help facilitate care being moved out of the hospitals and into the community. And then at the individual facility level, the Oliver Wyman team recommended that hospitals really explore and reconfigure their services based on community need and their financial position.
So I'm going to ask a question that is not on the, oh, you're not there yet. I'll wait for the next.
Oh, we have a couple of more sort of
Yeah, go ahead.
takeaway slides, but
Wanna
I'm happy to, no problem. Okay. So, yep, this is great. You know, you just made a comment of how easy, right? Like it's so challenging. And this slide, I think, was really getting at the how, which again is incredibly complex, but really the report encouraged Vermont to take a different approach to solving these crises, right? The approach they stated should be an intentional and proactive redesign of the state's healthcare system. You know, and just for example, the Oliver Wyman team predicted that Vermont will need as many as 4,000 more long-term care beds by 2040, and really prompted us to start thinking about how we are building that capacity now. So the sort of reactive, you know, siloed, site-specific approach is just not going to facilitate the state reaching its transformation goals or really Vermonters being able to secure access to timely, affordable, and high-quality care where they need it for the long haul, right? So the next slide here.
So let me, that's good. Go to that slide, but the slide that you were on kind of reminds me of my question a little bit. Because you did your meetings, not your meeting, the Oliver Wyman meetings that took place with the community were also with boards of directors for hospitals, and the governance structure is not really enumerated in some of these recommendations that are coming up. And yet it seemed critical that hospital boards, and I'm looking also at AHS here, because I know you're out working with hospitals now and the boards become critical, and maybe you could respond to this a little bit later. And how strong are boards in their oversight and their work with hospitals? For me, boards are the community members who are working with hospital folks to ensure access, quality, and low cost or cost effective work. So just that thought. And I don't know that there's a response needed at this point. But I think it's important, and I'm also looking at Devin Green, who represents the hospitals, the role that governance plays in making decisions is so important to our communities. So at some point, it would be helpful to have each organization respond to that question about the board. So it would be helpful. So that's it. I don't expect it now.
Oh, yeah.
You did work with the boards. I
Yeah.
know that, but.
So absolutely, it's a great question and one that was certainly thought about in the community engagement work. And the Oliver Wyman team was committed to bringing in hospital boards into the conversation. So at a couple different points in time where data was being looked at with the hospital, potential options were being discussed with them, members of their boards were present. And so we absolutely agree that wanting to bring it in and ensure that folks were all looking at the same information was really essential to the effort.
Yeah, so that's good. I mean, let's continue with this, but I think it will be important for us to understand what role boards do play. I mean, because I'm looking at that slide right there, and it says community driven. For me, that is board driven in many respects. So we'll just leave it.
So, this slide is one that's been shared and discussed in testimony over the last year. And, the report really offered strategies for the Agency of Human Services, the legislature, and the Green Mountain Care Board, and each hospital to consider. And again, I'd point you all to the full report for the specific details, but it's absolutely worth mentioning that some of this work is underway. And the different parties have really begun to explore the feasibility and impact of the different proposals and taken action. So, yep. This chart just sort of illustrates where we are now. Act 167 was passed in 2022. It was followed by Act 51 in 23 and then Act 68 in 2025. All these are key pieces of legislation that are helping us continue to move system transformation forward. So down at the bottom in the green boxes, you'll see, and as you heard today, right, the agency is leading the state's negotiation with the federal government on the HED, as well as the health system transformation work. And the Green Mountain Care Board is diligently building out a roadmap to implement reference-based pricing and look at hospital global budgets. And evolve our regulatory work so that efforts are aligned and really supporting broader state and system transformation goals. So our last slide here is just about some next steps. We are working with AHS to continue clarifying and refining our collaborative process, right? Some of our current efforts are focused on aligning the Green Mountain Care Board's review of the Notice of Service Reduction, which was a required component of Act 68, with AHS's transformation efforts. And we also need to think through how the board's payment reform and regulatory processes work alongside AHS delivery system reform, right? And there's a question mark here because, right, alignment in these spaces is really complex and evolving, and we're still sort of very much intentionally engaging one another in an ongoing way around this. So we also need to identify pathways to build out additional analytic tools to help us, monitor and evaluate service changes throughout the broader service delivery system.
And our hope across all of these work streams is really to maximize opportunities to be responsive to their community's needs and planful and transparent about proposed changes. So with that, I think we open it up to, questions and conversation.
I'm going to start with a question, and I know there's other questions. Obviously, one of the ways to demonstrate improvement is to demonstrate quality improvement. And the board has had some quality metric analysis. I know Hillary, you've been involved in that. I know others have.
You might be thinking of Hillary Wolfley.
Hillary Wolfley.
We often get one another's emails and yes.
You're right.
That's okay.
Yeah, but all of you are aware of what VPQHC does.
Yes.
And how that data is collected. It's claims data. We've asked for some, how can we integrate claims and other data? How can we make it broader? How can we integrate what the ACO has done for their quality analysis? All of those things are so important in determining outcomes. So question is, where are we with quality metric analysis?
Yes, I think it's a great question. And actually, I think you gave us some money to appropriate for VPQHC to do some contract work in service to this broader vision and goal. And so what we're working out with them right now is developing that inventory of what measures are hospitals responsible for and programs, and really thinking about identifying roles and responsibilities across the system. So I think AHS certainly plays a role. VPQHC is playing a role. The board has more of like a transparency measurement role. And so we're, kind of trying to flesh that out so we can all kind of start thinking about kind of our various roles and how those will evolve and kind of what we can bring to the table as these transformation efforts continue.
Yeah, I understand. It's not easy. Get it. And it does link in with our whole EHR issue. We will come back to this, I think, because resources, obviously, and look at AHS, understanding resources necessary to link in with community-based services in this whole area, and then how will it improve outcomes? How will it inform practice? Right. Okay, but it's ongoing. When is the report due?
We haven't set it, so it's not a report for you, it's a report we're asking you to produce, but we haven't set a timeline yet. So if there's a date you'd like an update, I'm sure we could bring something back.
Get that next time. That's good. Questions?
I think I'll say ahead.
Go ahead.
And your slide, as soon as you put it up, it struck me because it's something I think about all the time. Hospital sustainability, 2019 to present. And, we just heard from AHS around transformation efforts. And we go through the timeline. Are we conflating sustainability with transformation? I think of transformation as be something different. And I'm gravely concerned that what we're doing around transformation efforts has very little to do with be something different. It has to do with sustaining the system of care that we already have. You talked about, when you put the slide up, you actually said something to the extent of increasing revenue. I'm wondering if the board, as you've gone through the Oliver Wyman report and you passed this on to AHS, and your goal now is to support them in their efforts, I'm wondering if you're having, I don't want to use the word conflict, but are we at odds with what our goals are? And do you feel as though you will be able to make decisions as you start implementing reference-based pricing in global hospital budgets, that you're going to be able to make decisions around transformation, even if the directive that you're getting back has more to do with sustainability. I mean, and I know that you struggled this with your hospital budget process this year. I'm just wondering how the board is feeling about how they're going to be able to move forward.
I can't speak on behalf of the board members, but I can tell you that I think we have to be clear about what we can afford. And that really needs to be the first kind of discussion. And then I think we need to talk about, to your point, what will look different in order to have services for what we can afford. And so I think as you've seen in our slides, I think there's a lot of ongoing work to figure out those intersections and how it will work together. But I think your point about we can't maximize revenue. It's just not a viable strategy to address the affordability crisis. The solution to unsustainable system when we can't afford it is to transform. So we have to see something different. And if we don't plan it, it will happen anyway. We know that, we haven't talked about the federal level and what's changing. So, I mean, I think sorry, I'll just say it. So if we're not prepared with the backup plan, we will be in a lot of trouble.
I think it goes back to the question about business as usual or transformation and integration of the board and AHF. Really, it is the question of the day. It really is.
Following up from that, I guess my first question, which is a huge question, and then I'm gonna start with my first question, a smaller question. When I heard the AHS presentation of the process of the process, essentially, it struck, and I spend a lot less time on healthcare and all of this than most people in this room. So like newbie mind. It struck me as very, very similar to my understanding of the Oliver Wyman process and everything that the care board went through. And so I'm curious from your all's perspective, who are sort of really deep in the weeds of that first phase, where do you see effort being duplicated and where do you see like growth and development happening? Because it doesn't seem like we're moving to like implementation of your finding. It seems like we're seeking out further findings on top of findings. And I will absolutely ask AHS this.
I think that's a great question for them. I think we, we would love to understand how the decisions will get made and how those decisions are going to be aligned with part of the challenges. Really, as I mentioned before, like what are we driving towards? And I don't think we have a clear collective vision of what that looks like yet. And so, I think that I'm not sure how to answer it without kind of understanding where we're going first, right? And we all know change needs to happen, but I think we're less clear on what we want it to look like. Right? Yeah.
And I can just add, having had that outsider perspective that you probably did as well, and then coming into it, I think the Oliver Wyman report really kind of, and I think it was represented in one of the past slides that we presented to, was really the ideals of like what the goals were as far as like what we should be looking towards and areas where we should be looking towards. But I view the AHS work as like the implementation, right? Making, as Senator Lyons said, making those hard decisions about what change actually needs to happen. But I do think that the Oliver Wyman report was really helpful in that it kind of laid out kind of what are the high level things we need to be thinking about as we make these decisions.
And then the more complex question, I guess, is we're halfway through the meeting and like you just brought up the elephant for the first time. Like what in the work that you've done thus far is something that like needs to essentially be completely thrown out the window, and what has become even more important in the face of massive Medicaid changes and perhaps the loss of premium assistance? And like, if you don't know, like, what are you doing to try to figure that out?
I don't think there's anything to throw out the window.
That's right.
I think we're trying to solve affordability, and it's only going to become that much more challenging. And I think we're going to have to think about more creative ways than subsidizing healthcare through the commercial payers to make sure services remain available in our most vulnerable communities. So I think it's just magnifying the challenge.
Yeah. And I would just add, I think it's not only magnifying it, it's also it seems like there's a tangible timeline now, right, that we're looking towards and when these cuts are going to happen versus, as was presented earlier, the Rural Health Transformation Fund. And really, I think it's thinking about all of those things to inform what this is going to look like from not only process, but like a time frame of like when we really need to try to get this work underway and really substantively completed is how I'm looking at it.
I hear you saying like, same focus, same pressure, more pressure, faster timeline,
Yes.
or clearer timeline.
Clear timeline and say,
I'm just gonna follow up on.
I thought her hand was up, but it was your hand.
I'm just gonna follow up on Representative Kornheiser, because I think probably those of us who aren't steeped in this day in and day out basis, I have some of the same essence of what Representative Kornheiser was just saying, and I would say this to AHS as well. And I think it just took a while to sort of like percolate as listening to them and then listening to you. I guess I disagree with the thought that we don't know exactly where we need to go. We might not know how to get there, but I feel like both in the AHS presentation and the Oliver Wyman report and everything that I've heard throughout the last legislative session, we actually do know where we need to go. It's just that there's reluctance to go there. I think that's a, we got 3 decision-making bodies here between the legislature, the administration, the Green Mountain Care Board. And, I think we've all taken some actions to try to move us there, but I feel like, Rome's burning over here and we're deciding, when it's gonna, be okay to say to some hospitals, no, we're not gonna pay for that anymore at your hospital. So I'm just putting that out there that I feel like we need to move a little bit faster than we are. And yeah, we now have some like looming deadlines that frankly are going to happen before any of the rest of this stuff happens. And we're going to be left scrambling, trying to figure out, what we should have done, perhaps 6 months ago. So I'm just, I think somebody who's not in it, I'm not in it day in and day out. And that's the way it seems to sort of like the run-of-the-mill legislator sitting here.
So that is exactly the question that I was asking of AHS earlier. What are we doing now to make change and transformation? And I think Representative Kornheiser's observation that it takes the board and AHS working together without significant tension and with significant respect for this to happen. Because we're going to have decisions over here about reference-based pricing and maybe working with DFR and insurance solvency. We have that. And then over here, we have decisions about access in the community and et cetera. So that's just my comment. Senator Cummings.
Yeah, okay, go. The concern, I'm having a real mental disconnect between, well, we're having meetings and we're doing studies and everybody's doing this. And the sense of panic I'm picking up in the general public about what's about to happen. And we knew what we needed to do with schools 10 years ago. We knew our schools were not financially viable, many of them. But we didn't follow through on Act 46. We didn't do it until we hit a crisis last year of affordability. And I don't want us, these are painful. They're dealing with community control. They're dealing with people's jobs and their power but unless something changes drastically in Washington, which isn't likely, we're headed for the proverbial wall. And you don't make your best decisions when you're in crisis. And I don't know how we communicate that urgency, or you will get something done by now, or this will happen. Which I think might be what it's going to take. Because either the hospitals and the providers and everyone involved is going to help us figure out and do this, or we're gonna find a solution. And as I've said many times, they're gonna like the solution they find a lot better than the one we do. Because I don't know enough to make.
Well, we've made some good decisions.
We have, but not in crisis mode, and we're headed there.
Who's up?
I just want to clarify
Please.
something. Representative Wood, it's a great point. I think we know what we would like for Vermonters, right? I think what I meant to say was really about the trade-offs we're gonna have to make, given what we can afford. And someone has to make those hard calls. And that's kind of where the absence is in the room right now. And I think we've been looking to our hospitals to make those calls, and do we think that they're prepared to do that?
Well, but we heard
It's not the
from,
right place for them to happen. You know, I mean, because we are talking about broader healthcare, even though, you know, the vast majority of the healthcare dollar goes to the hospital. So I appreciate everybody's emphasis that we're not just talking about hospital transformation, we're talking about healthcare transformation.
I think I have another question. It's okay. If you look at the healthcare spending in Vermont since 2018 to 25, premiums have more than doubled. Hospital costs skyrocketed. Would you agree that the massive influx of federal money during COVID might have exacerbated the healthcare affordability crisis that we're currently having in Vermont?
There was a lot of fear at that point in time. And I think everyone was trying to just make sure things stood afloat. So I think this is part of, to Senator Cummings' point, when you're in crisis, it's really easy to throw a lot of money at a problem and not spend time to really be planful. And I think the more that we can plan in advance, think about how to use our one-time fund strategically and in a sustainable way that has the best payoff would be a good thing.
I do think, so I remember making these decisions as we were very cognizant about making sure that we used one-time funds for one-time things. But what we did is we pumped money into the system, and the system as a whole has become, I think, reliant upon that. Is there any concern with this rural health grant money that will be another large infusion of money into a relatively small size state, that it may, even though with the best intentions, we use it for, one-time investments? Is there concern that it will exacerbate our costs even more?
You just jumped into the next topic.
Oh, I did.
hold that thought.
Now.
I just have a very quick thing on this topic, which is, it's not even like a question. I imagine other people are tracking the reference-based pricing process better than I am. Can one of you have a meeting with me at some other point?
Sure.
Thank you. Great. That's it.
We do want to hear about the rural healthcare transformation, the grant that's coming up. I know that you have the health insurance rate review and budget review here. How egregious would it be if we skipped to the, we're going to do that after lunch, so we can skip to the rural healthcare piece. Is that something that you are going to be here for as well as AHS?
We'll be in the room.
Yeah.
Okay, all right, good. The question that Representative Black was asked, I think is really key, which is one of the reasons why this committee has tried to focus on where we are and what we're doing within the constraints in the means that we currently have, knowing that there might be money out there, but we can't rely on it going forward. Anyway, we're trying to focus on where we are and what we're doing. We also, this committee and our other individual committees is going to have to look at, and the Joint Fiscal Committee is definitely going to have to look at what are the consequences of the loss of everything that's coming at us, whether it's Medicare or Medicaid at the federal level.
And we might pick some of that up next week if everyone wants to carve that out in their calendar.
Of course. Okay, so let's move to, we'll come back to your next presentation after lunch. But before lunch, we have the Rural Health Transportation Grant update, which to me feels an awful lot like what Vermont is doing in some ways.
Okay, so we have two options here. When we were presenting last, you had a question about finances, spending. We can start there and then move to rural health transformation.
Let's go through the rural health
Okay,
transformation.
I'm concerned we would run out of time, but I don't want to not address.
We are, but so I'm thinking you're gonna have to just flex your time so that we have until 20 after 12.
Okay.
Let me see what, we're coming back
I
at.
am aware, JFO has reached out to AHS within the last week for details regarding financing with our business office, so I think you are gonna get concrete information on that. There, by no means.
That's good. No, I trust your judgment on this, on
Okay.
that, but we do need to see that. We have one slide from you, we don't have the in-depth slide.
You're gonna get, yeah, it will be in depth. Forever you.
Good.
Amy. Garvin here? Thursday.
Thursday, it's a week from today. It's a week from today, everyone. It's gonna be so much fun. Anyone who's coming.
Okay,
Thank you for your flexibility.
No,
Appreciate
thank
it.
you. Thank
Okay.
you. To talk about this.
For the record,
For the record, I am Sarah Rosenblum. I'm the interim director of healthcare reform at the Agency of Human Services.
For the record, I'm Will Dempsey. I am the Health Data Officer for the Vermont Agency of Human Services. I will dive in. Before we get too far, I want to just kind of do a little bit of table setting, which is this is quite the process that we're working through right now. You'll notice the dates on the left-hand side. The Rural Health Transformation Program, CMS, refers to it as RHP program. Published a notice of funding opportunity. They refer to that as a NOFO. On September 15th. Applications are due from states on November 5th. So not a very long application period. Only states can apply, and only the 50 states can apply. Territories, DC are not allowed. Neither are municipalities, health systems, et cetera, et cetera. Application determinations will be made by New Year's Eve of this year, and then funding will actually start flowing in early 2026. So we will be getting the money up front through this particular opportunity. And the funding will be coming in tranches, is the way that CMS is framing it. So it would be coming in per federal fiscal year, and we have until the end of the next federal fiscal year to spend the money that we get the prior federal fiscal year. Any funds remaining from what's allocated to us will have to be given back to the federal government.
2 years.
So it's
Per
2 year
tranche.
per tranche. So it's a $50 billion fund. 25 billion of that will be split evenly between states that apply and are accepted. So that's $100 million a year per state over 5 years, so $500 million. The other 25 billion is split between what they refer to as workload factors, that's state policies that are in alignment with federal policies, or if the state is willing to, any state is willing to agree to be in alignment with those federal policies, as well as things like rural factors. So how rural each state is, uncompensated care that happens in each state. And actually the square miles of each given state is a significant factor as well in that funding bucket. So,
Question.
Yeah, well, two questions on the two different parts. Have you gotten all the guidance? Oh, I guess you're writing your first one for the 25 million. Approved states, what are the odds that you think we're going to be approved in this first tranche? I mean, are there weird things in the application that are concerning, or is it a pretty straightforward, all you have to do is fill it out and you'll get accepted kind of application? That's the first half.
can I start there? And then we
Yes.
can go to the second half, Representative. Thank you. So we've been hearing from CMS that as long as states are meeting the requirements, which are a complete application, there are no policy implications on the baseline funding, that $100 million a year for 5 years. They anticipate making awards. Obviously, CMS doesn't make promises,
Right.
but that's the directionality that we've been hearing.
Compliance with the application
Okay,
requirements.
and nothing weird in that for Vermont. Okay. For the second one, I'm a little more concerned about with state policies aligning with current federal ideology. Is
Sure.
Do you already have information about what they're talking about there?
Yes, so they've provided scoring criteria in the NOFO of different policies and how they're going to score on those. And we've been doing an analysis with our other partners in state government on those different policies to see where we are in alignment based on Vermont's based on our values in Vermont. Things like nutritious lunches in schools and those types of,
Is diversity included as part of this?
no.
And maybe you'll get to this later. It all sounds like a lot of money, but they're also cutting a lot of money on the other side. And it's my very limited understanding that this is not going to make up for the cuts that we're going to get. Is that?
Now, can I take that?
Please.
Do you mind? While we're hanging out on this slide and before we kind of move forward, that kicks off like a broader principle about how we are thinking about this money. So I'm going to start there and talk about some of the other broader principles. The first one is, you are exactly right. This is not going to make up for the amount of federal funding that is being cut to the state of Vermont. It's not intended to. It is intended to be like a,
Feel good.
here's a little something to make the hurt a little less. And we should not think that it's going to make up for that. The other piece of it, and this goes back to Representative Black's comment in the previous session, is that the money is going away. So even if our application is approved, we will start having money in 2026. We get reassessed every year as to whether or not we are doing the right things with that money, making enough progress, doing the things that we said we were going to do. And if we don't, we are at risk for losing that money. Again, even if we perform and do exactly what we said we did on exactly the right timeline, even overperform, the money ends in 2032. So a big part of this process as well has been, what do we do with an influx of funding that we are not going to create a problem in 2032 when the funding ends? A tangential point that, and actually I'm getting a little ahead of Will and he will get to this, but as we've been having this discussion within the state for the last month, a lot of folks have said, okay, great, give this money to providers and help providers, given the state of the healthcare system in Vermont. We are not allowed to use this money to pay for services. So this also ties into your first question about federal cuts. We are not allowed to use this money to pay for anything that an insurer may pay for, whether that's Medicaid or private insurance. Okay, and the last principle I want to mention is that, where's that going? We have to get this money out the door quickly. It is coming in early 2026. It is not a small amount of money. So just like the logistics of moving money from a state government entity to potentially other entities is complicated. And I think starting, a fresh program on January 1st is going to make it really challenging to get, for example, the first tranche of money out within 2 weeks. So that's the third like core principle is what are things that we can include in the application where we are going to be able to get the money out the door? Because again, if we don't get the money out the door, it's gone. It gets taken from us.
So I'm looking at your next slide and it has the three goals that are there. And as you're talking and I'm looking at this, a lot of things that sort of come up. So strengthen our rural healthcare workforce. We already have put significant work into a framework for encouraging workforce and loan repayment, et cetera, et cetera. That fits right there. So that can go out the door right away. Theoretically, you might tweak
No,
a
I
little
think that's a
bit.
great example. Exactly.
Secondly, increase access to timely care across rural communities. Transportation, does that come up? Can we invest in transportation? We can't invest in services, but we can maybe establish some core transportation or telehealth or HIT. All of those things come up and things that we've been working on that fit there, maybe some tweaks. And then the third one is expanding innovative strategies to increase quality and reduce healthcare costs. I think about all the work that we just heard about from Green Mountain Care Board on quality metric analysis. Money can go out the door there. So it seems like a Herculean task to get money out the door. It'd be great if we had it to get out the door. But it seems like this fits with the things that we're doing, and it probably just requiring some of that coordination to make it happen.
I think that's right. I think that goes back to my point at the very beginning of our presentation, which is we are already doing this work in the state of Vermont. We already have items, as you just enumerated, under each of these goals that we could spend money on. This is not oh my gosh, we have 1 month to write an application and let's start with a blank piece of paper and start whiteboarding. So I think you're exactly right, Senator Lyons.
So the other part of this is how this dovetails with or does not dovetail with.
I can talk a little bit about that. Yeah, so we're doing a policy analysis right now, and it's not just within AHS, it's also with the Agency of Education, Agency of Commerce and Food Development, Agency of Agriculture, Food and Markets, to look at those policies that are in there. And I do want to just continue to reemphasize that only impacts the funding above that $100 million a year that Vermont could get. And we have a straw is not the right term, but we have a third party analysis that was done by a center at the University of North Carolina. Straw, sorry. Thank you.
Preliminary. How about preliminary?
Preliminary. And it was a third party assessment that was done by a center at the University of North Carolina that looked at all the different factors in the NOFO and looked at different data sources throughout states and evaluated the states. Vermont came up middling in that analysis that was done by that third party entity. And part of that was things like our physical size and our population are significant determining factors in those funding sources. And we are small in both of those regards. So we're looking at where it might make sense to pursue potential policies and where it doesn't align with Vermont's value system to pursue policies. I'll say in the read, some of it's pretty kind of boilerplate, folks practicing at the top of their licenses for physician assistants and things like that. Things about bringing back the presidential physical fitness test in schools.
Oh, God.
We're not advocating.
How many pull-ups can you do? Still have good mama.
Yes.
Climbing the rope.
We've all been comparing.
Just distracted the whole
I think we all have those points.
That rope ever again.
And things along those lines. I think we all were comparing who had the certificate or not from elementary school and high school.
It was bad enough, on God.
And so those types of policies, we're going to take a very practical approach to what that is. And the governor has said that he would be taking a very practical approach to that as well. It needs to fit Vermont's values.
Can I ask a follow-up question about that?
Please.
So, I don't really know what a practical approach means in reality, but, and, I think what Vermont values are is also very much up for debate. And you also have to write an application on an unbelievably short timeline.
Yes.
And so I think this might be one of the few opportunities to actually surface some of the places that you might have questions about a direction that you're going that might turn out to be at odds with the general legislative directive and or direction. And so I wonder if there's anything that you do want to sort of surface now, so we're not all just yelling about it in January when it's too late to do anything about it.
No, I appreciate that. I don't think that we're prepared to raise anything in this moment with you all. I think the perspective, honestly, there's a lot of, and Will very briefly touched on this a few minutes ago. There's honestly a lot of things that we already do in Vermont that, per their black and white text, is in alignment. Will mentioned like healthy school lunches with farm fresh food. There's the same thing within our jail system here, prison system. There are a part of the work that we've been doing. Actually, I think the most amount of time we've spent in this space has been on cataloging things that are already happening in the state of Vermont, that are already part of our policy framework, that we can then include in that section and say, look at all these things that we already do in Vermont that align with the direction that you're heading. I could not name for you right now that anything I'm aware of that we have plans to make a significant policy change in this application.
So, I mean, there might,
Can I ask that if you run up against one, and I think significant is another one of those words like practical, that you reach out to us and maybe we could have like a quick virtual.
well, that's exactly the point.
Yeah.
Thank you.
Yeah.
We don't need to meet again before November 5th. But it would be extremely helpful for us to see what you're proposing. Because joint fiscal will have to sign off on the grant. And it would, I think maybe it's a joint fiscal issue rather than, what this committee would also like to see it. Most of us are also on joint fiscal.
I was gonna say, let's say you can, we'll get.
Go ahead, sign it.
So it would be great to see the proposal. It's difficult if we see the proposal the day before. This is really huge. So at least a week before.
And we appreciate that. I think, we've already met with you, Senator Lyons, and other legislators on the subject of this application. We are happy to meet again, whether that's before November 5th or after November 5th. And I think there is also this specifically fiscal component that I believe our business office at AHS has already been in contact with JFO as well about those logistics and what will have to happen should Vermont be awarded.
That would be helpful because the meeting that I had was really informative about what is in the grant, what's not in the grant, how it links with MAHA. It really wasn't to have any discussion about suggestions. But I'm looking here at the page where you have approved states funds or ICMS to invest in at least 3 of the permissible uses below. And I see prevention and chronic disease, which Vermont has been leading on a great deal. And I think about some creative new ways to do that. For example, I know there's a bariatric program at Dartmouth for chronic COVID. Would be great to have that in the state of Vermont because chronic COVID is huge now. It's just emerging. People cannot do anything when they have this disease. And to prevent that, how do we prevent that? Maybe we're not going to be in line with CMS, but we think COVID vaccination is critical. So there are some things here that I think we can come up with that will be extremely helpful. I look at the mental health and substance use disorder and similarly thinking about a local clearinghouse for recommendations for recovery for patients and how we can put that out into the community. There are ways of using the money to get coordination rather than direct services.
Yeah, no, I appreciate those ideas. I think please continue to send them along. We are on a very tight time frame. We have to have this thing written in the next 2 weeks. We have been welcoming feedback. We have an open comment page on our website for any Vermonter to send along whatever they choose to recommend. But we have limited time. But I appreciate your thoughts, and they are welcome. They are read, and they are contributing to our strategy for the application.
I think it was helpful for me to look through those, what do you call them, the straw something or others?
Straw something.
The straw models in the appendices to this, because what I was struggling a little bit with is, you know, I hate going after, you know, even if it's a pretty significant size grant money, if it's not going to support and facilitate things that we're already doing or should be doing in the state. So you know, when I looked at the different straw model approaches that you had, most of them I could figure out how to tie in, which obviously you were doing, to our transformation activities. And, you know, that might be, I appreciated that, I guess is what I'm saying.
Oh, thank you.
I think that that's helpful. I'm not sure if I agree with all of the different things, but I appreciate the connection with the transformation, because that's what we should be doing with this money.
Yeah.
Transformation in and of itself is giant, and we have to figure out a way to make this money be useful to us in transformation.
You want to go there now, as
Yeah.
far as the straw
Keep
model?
going. Yeah, take a little bit
I think we
of time.
skipped a couple slides.
We can sacrifice a little bit of our mortality.
So one slide we skipped is just the timeline, so we don't need to get too deep.
I actually have a quick timeline question.
Please.
Do you foresee that the shutdown is going to impact the deadline in any way?
No, it's
Great, thanks. Cool.
essential.
Yeah. Yeah.
And we talked with the federal delegation a bit about that yesterday.
Thanks.
So we can continue on. Just want to give you a highlight of the stakeholder engagement that we're doing relative to this, and the different types of folks that we're meeting with. So mentioned the federal delegation. We meet with legislators both biweekly with the Green Mountain Care Board and the Healthcare Advocate, as well as monthly through a meeting that the Healthcare Reform Unit has with legislators that's standing. We also are meeting with various state agencies. They're all listed there. I won't acronym all of you too much. As well as directly with the Office of the Healthcare Advocate through the meeting above, and the Medicaid Advisory Committee for the state has been
I
engaged.
don't see the FQHCs on that list. Am I missing something?
So, yeah, so if you look by state primary care.
Thank you. Is that what that means?
Yeah.
They represent FQHCs. And then we have weekly meetings with a coalition, including a wide variety of different partners who are expressing the needs of their respective states.
And we have the open comment box, as I briefly mentioned, and we've gotten approximately how many?
We've had 55 unique individuals and organizations do outreach through our public comment box. Other comments come through state employees and different things like that, but that is the source where we are pushing people to try to keep everything logged and tracked, and we're keeping all of the materials in a SharePoint site that we receive. And we do respond to all of the outreach that we get to at least acknowledge, thank you for submitting this. We will take it under consideration and review it to make sure folks aren't wondering where their comment went. So
Is the funding for Minot Health coming from the current dollars allocated to transformation, or will it come out of the $100 million potential? How will that happen?
It's coming out of our current already appropriated funding for transformation.
I can't pre-bill the fund.
No, I understand that, but we can pay ourselves back.
We can look at that.
Okay.
Okay.
I mean, because that wasn't a direction for those funds. Well, you did have direction for consultation for the transformation. I suppose we could consider this to be consistent with that.
I think our intention is that it is consistent with that.
Yep. I think you can go 2 forward. So this is just, could you go back 1 just for a second, Brendan? So these are things that are just not allowable. I don't think we need to get too deep into it. Big ones are construction. New construction is not allowable. Only minor renovations. We can't pay for services. We can't supplant existing funding. That's pretty standard. And there's just caps around different buckets that we can utilize different funding for, including EHR, EMR replacements that are paid for through high tech. Can't do broadband stuff. And then it's more standard federal interagency transfers and lobbying. So I think we can continue forward.
Part is here, just-
Okay, so this is the regionalization slide. This is our straw model that we built to conceptualize how we're approaching the application. So you see it's in 3 different colors for 3 different layers. You have the what at the top, which is supporting the regionalization and transformation work, Representative Wood, that you mentioned, and tying it back to that. So that way we are following that thread all the way through our work. And we included the types of providers that we will work with through that regionalization work and are already working with. And mental health and substance use disorder isn't defined on the slide, but would make the bubble really big. So then underneath that is the how. How are we going to do that transformation and that regionalization? And the buckets that we've come up with are redefining how providers work together through horizontal shared services. This would provide independent providers and practices and hospitals throughout the state access to services to reduce their costs and allow them to share both technical resources as well as potentially clinical resources and back-end options. Like they've talked, hospitals and other organizations have talked about shared HR systems, shared electronic health record instances, and things like that to further reduce costs and ensure that they're competitive. We also have primary care and in continuing the work that Blueprint's been doing for some years around primary care and growing that. And we're coming up with how to evolve primary care through the Blueprint. I want to just emphasize primary care is what we want to focus on. Blueprint is the tool that we are going to use to complete that work. We also have healthcare workforce development. This is all of the things that exist today. Senator Lyons, you mentioned a few of them, and continuing that work forward. And then scaling existing clinical innovations. So this is what are things that exist in Vermont now, concepts, physical systems, as well as clinical offerings and services that we can help support with this money in a very sustainable way. And to your point, Representative, a sustainability plan is required for our application. So we are thinking about sustainability as we're talking about where to put the money. So that way in 5 years, we aren't at a cliff. And then underneath that, we have infrastructure supports. So this is kind of the foundation that all of the above rests on. And you'll see things like IT solutions, our health information exchange here in Vermont, and the state being a place where we are able to encourage incubation of ideas, collaborating around payment and with providers and payers, and doing transformational supports. So this is like the logistics, the people, the consultants, technical assistance, training, the how do we get from A to B, that is resting in that lateral. And then finally, state policy. Sorry, you're in my blind.
That's okay, I'm just close enough to lunch that reading slides out loud is hard for me. It's not you. Where does transportation fit into all this?
It fits into that scaling existing clinical innovations bucket. It actually fits in 2 places. One is within regionalization. You already heard Dr. Soroyan talk a lot about transfer centers and how that's a big topic within that work. So that's one area in which I think we'll discuss transportation. The other is in the context of EMS and the mobile integrated health program, the MIH program, which currently operates in Brattleboro, and we're hoping to scale that program. So
I think that leaves out like the vast, just like normal people trying to go places, and especially older folks or disabled folks trying to go places. And so like Medicaid rides doesn't really work in my region. Maybe it works in the rest of the state. I don't know, but I doubt it. And then all the folks that aren't eligible for Medicaid, especially the fact that more people are not about to be eligible for, like how all of those people get to places that are further away.
yeah,
And people are working and can't drive them.
no, I think it's a great question. The one other piece on transportation is mobile vans for both dental, medical, lab work. That kind of gets to your point.
No.
I think we run into a problem there with NEMT or non-emergency medical transport, and that's a service that we can't use this money to spend.
So where, like, but if you were thinking about where it even fits into the planning process,
I mean, it's part of
Be
the,
funded somewhere else and still be part of the system that you're right? That you're funding the transformation of.
I would say that this graphic is limited to what we are including in the application and asking for funding for from the federal government. So
So you're in this proposal, you are laying out essentially a vision for funding a huge part of the transformation process.
Yeah.
I imagine, given that you have the whole of government at your disposal, you're thinking about other aspects of the administration that will feed into this transformation vision. How does transportation that might be funded another way maybe fit into?
I don't think that is not where we are right now.
Okay.
I think that's part of the statewide healthcare delivery plan that's coming in 2028. But I think we have a very limited amount of time to complete this application, and where we are is what we are asking for funding for within that.
Other questions? Right, it's kind of chicken and egg here, isn't it? Using this money to accomplish our transformation goals, but at the same time, we may have different elements and values associated with what we have in our underlying legislation. Could be different from what's in the NOFO.
Yeah. That's part of the
Specifically-
challenge.
Yes, specifically
it's
for the
the balance.
funding of.
Yeah.
Is it not?
Yeah.
Can you speak a little bit more towards the workforce development, what your ideas are, what your thinking is behind that?
Yeah, so we've engaged our workforce development director, that's in the healthcare reform unit, who has a steering committee that works with providers from throughout the state and has for a number of years, and has gathered a tremendous amount of information around what's the current state, what are providers looking for, what's worked, what maybe needs some tweaks to continue to flourish. So we're talking about things along the lines of, and this is all possibilities, not absolutes. Things like grants for providers to be able to move here, things where we could help support them to move to Vermont. We're also talking about how we could support housing for the healthcare workforce in Vermont to try to reduce that barrier. We're looking at things, more traditional things along the lines like student loan forgiveness, apprenticeships, in practice supports for folks to be able to advance in their licensure, as well as pipelines and how to work with existing programs from throughout the state. An example could be like the Maple Mountain Consortium to try to grow in an independent residency program in Vermont for providers like MDs, but also keeping an eye on how do we deal with and support nurses of different levels, LNAs, RNs, NPs, et cetera, and try to really grow our healthcare workforce as both from bringing people to Vermont as well as growing people who are already here.
And retaining them.
Thank you.
Can I ask a follow-up? to that
Yes,
quickly?
we go 1, 2, 3.
You know, we concentrate so much on workforce, and I've been thinking more recently just about, and Will, I always think of you as the IT guy. So,
It's a hard hold to break.
no, I mean, we sort of built our expectations around workforce, around what we've needed in the past, what we're foreseeing in the future by delivering care the same way that we deliver care currently, the same way we have delivered care in the past. And, you know, with the recent explosion of technology, especially coming into the healthcare realm, are we adapting what we really think our workforce needs to be with what it needs to be in the future? Because I'm imagining we're going to need to scale back on our workforce in the future if we are able to implement emerging technologies in a more robust way than we currently do in this state.
So I'm happy
More
to.
computers, less people. I know you'll love that.
Have to be careful. So we are
What you wish for.
including concepts like AI transcription, decision determination systems, things like that to support providers to be more efficient in the roles that they have and try to also address workforce shortages through this funding as well. Those are concepts that we are including, and keeping an eye out for how can we use the latest technology to try to address some of these gaps that we are experiencing in Vermont over the long term.
I think you're right. I think a portion of this too is like Vermont does need a more workforce. We're still over reliant on traveling nurses, which is still a huge line item for many of our healthcare facilities. So I think it's a both and, to your point, like there's certain roles that I think, yes, might scale back. And then there's certain roles that might not scale back, but need to be substituted by Vermonters instead of temporary people who are here for 6 months and do not stay in Vermont and are potentially more costly than a Vermont resource.
Always gonna need somebody to make the beds. All right. I want to move on to Representative Shy and then Senator Cummings. So, and then I have a question and we're going to stop at
Okay.
12:30.
I think we've done a good job funding the whole LNA to nurse pipeline over the years, and Vermont State University is doing a really great job in particular, and now we're up to a place where they can train like 1,000 nurses, and so I'm really happy to see all that. We had put in the budget money for Maple Mountain if we were able to. Yeah, so, and that hasn't happened. But what I'm hearing, I think you say is that we might be able to get money to help make that actually happen.
It's something that's being discussed, yeah.
Yeah, okay. I'm really interested in homegrown opposed to paying people to move here. We've done that before with other things, and it's not a good use of our money. There's no evidence that it actually caused people to work here. It was like, oh, I got this nice bonus because I was going to move here. So really like that. So I'm glad to hear about it.
Thank you for the feedback.
Senator Cummings.
Yes, when we're talking about transportation, I'm wondering, most of our small rural volunteer services like Fast Squad and EMTs across the board, we're having trouble getting people to volunteer to do anything because so much has changed. And I also know there was an ongoing issue with, you had to go, I think it was to the Fire Training Academy to up your credits. And people just weren't willing to give up a whole Saturday or Sunday and drive 2 or 3 hours. So part of this might be, if you're going to have to transport someone that is in crisis, so they're in need professional transport. How do we do that? And where are the hubs? How do we move people?
No, I think you're exactly right. I will say we briefly touched on potential EMS reform and regionalization that might happen through this funding and the MIH program. Part of that too, Senator Cummings, my understanding is, and I'm not an expert, but my understanding is that there are limitations there regarding how EMS is paid. They're only paid for a very specific use case, which is very limited. And part of the vision here is that we are changing what they're able to be paid for as well and trying to better support them. So we have, to exactly your point, a more sustainable system.
They're only paid if they transport.
Exactly.
They're not paid to treat that they run.
And if I
And I think only maybe transporting to specific
Right.
locations, right?
Specific
Exactly.
locations.
Exactly.
Does make it tough.
And Senator Cummings, you touched on this, and it's something that we talked a little bit about is also like licensure for things like EMS and how we could help defray costs related to supporting folks that want to pursue something like that type of licensure through the workforce development work.
I have a question, and I don't know that you can answer it, but for me, it's critical. I know as we go through change, there's a lot of tension. There's discomfort, both in the community, but also within the organizations that are responsible. And so the culture of change for me, I see a lot of turnover at AHS. And I do hear that there are concerns within AHS about cultural issues. And so my question of you is there a culture within your organization that is supporting the people who are doing the work, and including those who are within your organization and those that are outside working with you? So I will just ask the question, but I think it's absolutely critical if we're going to move forward, whether it's with this grant or with our ongoing transformation, that we see that that the support and the caring, AHS is a caring organization. Theoretically, are we caring for the people who need it the most, who are doing the work? So I will leave that question on the table and just say, thank you. Thank you for your work and for everyone who's testified today. I know it's hard work and it's stressful work. I don't sleep at night sometimes because of this, a lot of times because of all the work we're doing. And I can't imagine what it's like to be in your shoes. So just say thank you. And we're going to take a break for lunch and be back at 1:15.